Sri Suvananukon, quick question to you. Thank you for that presentation on MPNs and, especially all the new drugs that are coming in. We have been familiar with ruxolitinib, but with fedratinib, pacritinib, and momelotinib, which you all just mentioned, I just wonder about the toxicity profile of these drugs because you did mention that for a lot of patients we would resort to observing them for any sort of progression. So, would starting them on these therapies, and especially for maybe, if you, for example, if you're just treating an asymptomatic low hemoglobin or an asymptomatic low platelets, does it really warrant putting patients on these drugs? And if so, are they tolerated? What exactly are you affording these patients when you start them on these new therapies?
Yes, that's a great question, Dr. Rajiv. Thank you. And I think that the broad answer to that is, always thinking about the patient's perspective and the patient experience, because these diseases are, especially myelofibrosis, diseases that likely they'll be having to live with for many, many years to sometimes the rest of their lives. So side effect toxicities are something that's always top of mind. For patients that are asymptomatic, that's mostly why I don't recommend starting a JAK inhibitor. But regardless of that, I actually do find that most of these JAK inhibitors are very, very safe. And maybe anecdotally, over 80–90% of my patients benefit from the therapy and don't suffer from any side effects. So actually, I reach for them quite often when I feel I need to. But certain side effects that I'm really cautious about are reactivation of viral syndromes such as shingles and hepatitis, as well as low blood counts that I need to change the dose for.
Hmm.
But overall, they're typically very safe.
Got it. And is it a fixed duration treatment or is it an indefinite treatment until you see improvement?
So I typically have indefinite treatment for my patients,
Hmm.
but there's a lot of switching therapies. And even here, with the bias of being an academic institution, we have a lot of clinical trials available as well too. But the general paradigm is we would use it for as long as it works, or we would use it for as long as we need to get them to a transplant for a cure.
Sounds great.